Right, welcome everybody. I've got two apologies from Michael Meyer and Anna Bradley. We're just looking for Camilla's name. She's anonymous at the moment. I think it is coming, actually, Camilla, apparently. Is everyone happy with the minutes, the last meeting?
I think there was an error, actually. Number 23. Point 23. Was it the RGBC that's commissioning the audit, or was it the Audit and Risk Committee? I thought it was the latter.
No, I think it was the RGBC, actually.
It was the RGBC?
Yeah, it is, yeah,
Okay.
yeah.
I thought Paul said it, but anyway.
I think, Paul, you may be involved in it as well, but it's...
I spoke to David and that was the way.
Okay, that's fine.
Okay,
Yep.
thanks. It's good to know you're reading the minutes anyway.
It should be the chief exec, I think, is upon Paul's.
Right, David, your report, please.
Good morning, everybody. Thanks for this. So, David, what I propose is to present this in a slightly different way than I've done hitherto. I think the topical issue is Hinchinbrooks and our inspection of Hinchinbrook and some of the publicity that has surrounded Hinchinbrook. So what I propose to do is, rather than present all the items in this, is just go straight to the update from the Hospitals Directorate, which is item 4 in my report, and then following that discussion return to the meat of the report. We're joined by Jonathan Fielden, Professor Jonathan Fielden, who chaired the inspection, who's sat at the end of the table, and next to Jonathan is Fiona Allison, who was our head of inspection, who led the inspection from our point of view. So they were the colleagues that were actually on site. But I think Mike's going to kick us off into this aspect of it. There's then a secondary issue about process and declarations of interest, and Mike will touch on some of those, but Sandy and Tracy Dennison might also make a contribution when we get to that particular point as well. Tracy's sat in the audience at the minute, but we might invite her to the table for that bit of the discussion. But if I hand over to Mike, and as I say, I'll then come back and once we've completed that discussion, go through the rest of the report that we've got. So, Mike.
David, thank you. As board members will know, we conducted an inspection, a comprehensive inspection at Hinchinbrook in September, between 16th and 18th of September. This is now what I would call a routine new approach inspection. I think I counted up, it was our 68th such inspection of acute hospitals, and we've now done a total of 87. It was low risk according to intelligent monitoring. It was in band 6. We were not anticipating any major problems. The inpatient survey was average. Their mortality rate was not elevated. They did, on the staff survey, have more responses that were in the bottom 20% than in the top 20%. There were 2 in the top 20% and 14 in the bottom 20%. We've subsequently had the publication of the A&E survey, which showed again that they were average on that. So we took a team of 29 people plus logistic support into Hinchinbrook. That was the chair, that was Jonathan Fielden. We always have either myself or a deputy chief inspector or a very senior external person chairing the inspection, working alongside a head of inspection, in this case Fiona Allinson, and an inspection manager as well. On this occasion, we did also have one of the deputy chief inspectors, in fact from Primary Medical Services, Ruth Rankin, was observing the process, having fairly recently joined the organisation, and was just looking at how the hospital inspections were going. In addition to that, we had 6 CQC inspectors, a total of 8 doctors, 6 of whom were consultants and 2 were juniors. We had 7 nurses or midwives, again 6 who were senior, at matron level or above, and 1 who was a student, a head of governance, a pharmacist, and 2 experts by experience. I think it's fair to say that the team were shocked by the care that they observed when they went into Hinchinbrook, sufficiently so that Fiona actually contacted me during the inspection to inform me of this, and as you will hear from her, she immediately had asked the chief executive to go to the ward to see what they had seen. Again, we took the step as a result of this of advising the Trust to reduce the number of beds on one particular ward, Appletree Ward, to relieve pressure on the staff. And again, we then went back and did an unannounced visit to that ward within 48 hours and actually did observe that that had relieved pressure, and in fact, I believe one of the patients commented on how much a change that had made. But it wasn't just about that ward. There were very major concerns about A&E and surgery, and others can go into that. Sufficient all of this that, first of all, Fiona wrote a letter of concern immediately at the end of the inspection to the Trust. I followed that up with a letter of concern a week later, and because we wanted to make sure that all the major concerns that we had across the Trust were known to the Trust so that they could be taking action on them immediately and not waiting for our full report, which inevitably takes time. We've then had a series of meetings with the Trust and people from Circle. We then took the report through our normal processes of a National Quality Advisory Group that was chaired by one of my deputies, Ellen Armistead. We sent the report out to the Trust for factual accuracy checking in November. They sent us their comments back. There were a lot of comments, so we gave that a very thorough review. That did end up with some changes to the text, but no changes to the ratings that we were recommending. The final report went to the Trust on the 5th of January. That was followed. The Trust asked me if I would speak to them by phone, and I did so on the 6th of January, speaking to the Chief Executive and the Medical Director at Circle. And it was at that point that I informed them that we would be recommending special measures. We obviously recommend that to the Trust Development Authority. And then we know that Circle held a board meeting the following day. The Quality Summit was on the 9th of January, and that was immediately followed by publication. And as you will all know, we said in the report that both A&E and medical care were rated as inadequate. And if we look at the 5 key questions, safety, caring, and well-led all came out as inadequate. I think it is important just to say that critical care, maternity, and the outpatients were rated as good throughout. As I mentioned earlier, I have spoken to Ruth Rankin, who was there as an observer, and I asked her 2 questions. First of all, did she think that our report was a fair assessment of quality? And she said she thought it was very fair. And secondly, I asked her whether she felt there had been any evidence of bias amongst the team, and she had been observing the corroboration and challenge sessions very closely to see how we did that in the hospital's directorate, and she emphatically said to me, no, she saw no evidence of bias. So that's where we've got to, but I think it would be better to hear from those who were actually on site.
Thanks, Mike. Jonathan, you were the chairman of the inspection team. Do you want to just kick off and give us your impressions of the inspection, and maybe just a little bit about your own background beforehand? You need to press the button.
Thank you very much. If I go over my background first, I'm Dr. Jonathan Filden. The elevation to professorial level is gratefully heard, but I'm actually merely a doctor for that. By clinical background, I trained and became a consultant in anaesthesia and intensive care medicine, appointed firstly in Royal Bucks in Reading in 1998, medical director there from 2009 to 2012, then medical director of Medicine Board at University College London Hospitals, and I still maintain a hand in intensive care, so that's my clinical background to that. This was my first inspection, but we went in with the information. The team came together very well during the first day, and it was very clear that the focus was on ensuring the best quality of care to patients. As soon as we identified issues, particularly in Appletree, but also in A&E and across medical care, and in some areas, as highlighted in the report, surgeries and end-of-life care, we highlighted the issues particularly around Appletree. Those were then highlighted locally, back to check, and then I think the things that came through was the lack of immediate response to those at a level that we would expect. I think probably looking at a high level across it, I think for safety and quality to be assured, patients need to be heard. There was clearly strong evidence that patients weren't being heard, be it call bells or that information coming through. The next line of defence is staff need to be heard, and it was clear that many members of the staff were absolutely passionate and about trying to provide great care for patients, but found that quite difficult. The leadership were very stretched and somewhat inexperienced in some of the areas, and the nursing voice was not heard. That, I think, was one of the strong points that came through. Then, if you like, the triangulation mechanisms for ensuring that you're picking up what's going on, which as leadership you need, were clear that when asked who was holding who to account, which is the logical question, Circle said Trust Board said Circle, and the executive weren't exactly clear. It was then clear that events weren't necessarily learnt from a previous ward about 3 or 4 months before, very similar problems coming through, and therefore the governance mechanisms to triangulate what you may see by wandering around as an executive, and being an executive in my own organisation, you can wander around and be told one thing, but you need to be triangulating and hearing for all that didn't come through. So we highlighted the particular issues on Appletree, and again, it took more time than I thought for the executive to act. And that together brought us to the conclusions that you see in the report, which are very much focused, how do we get the safe and appropriate care for the patients in that organisation for it. There was, in the corroboration sessions, the challenge sessions, I didn't perceive that there was bias. There were just experts by experience, clinical experts, staffing experts, and the inspector experts of inspection, if you like, absolutely focused on aiming to get the highest quality care for the patients. Fiona, if you want to.
Again, just a bit about your background first, and then your sort of perceptions as well.
Okay, I'm a registered nurse. I trained in the NHS and got to ward manager level, predominantly in surgery, but did dabble in medicine and critical care theatres, and then left the NHS and worked in the private sector for approximately 5 years before joining the previous regulator, the Healthcare Commission, in 2005. So I've been a regulator for nearly 10 years. I've undertaken 19 inspections under the new methodology. Most of those are comprehensive, but obviously responsive as well. And I've undertaken 2 independent healthcare inspections as well to date. So that took us to Hinchinbrook, whereas everybody has said we didn't expect to find many problems. The information we had beforehand was very much either middle of the road, or stakeholders had no concerns. There was a minor concern around infection control, but it was only minor, which was being addressed with the CCG. As Jonathan says, the team bonded very quickly. There was a very upbeat mood amongst the team, and on day 0, we had a presentation from the trust, as we would normally do. He told us about the Stop the Line process, and we were all very keen to explore how this, what was seemingly a good initiative, would work in the interests of patients. On day 1 of the inspection, when we were on site, we had an afternoon corroboration session where an expert by experience was particularly concerned over an incident he'd witnessed whereby a patient had been given some soup, had pushed it away, the carer pushed it back, he pushed it away again, the carer pushed it towards the patient and it spilt over the patient, and then he was berated for what had happened. I think that, and the fact that one of our inspectors had witnessed an unsafe moving practice, suggested to the medical team that they attend early the following morning. We'd had some reports about night staff being short on numbers than days. So they attended about 7 a.m. and witnessed a series of emotionally unsupportive behaviour Such was it that we ensured that the Trust reported to the NMC, one member of the ward team on that day. As Jonathan says, we highlighted to the management at lunchtime, but it took a long time for actions to start being taken. I was sufficiently concerned. I had never witnessed that kind of behaviours in a care home or in an NHS trust in my previous career. I spoke to Ruth Rankin and contacted Mike, and we obviously talked to the trust and fed back in explicit detail what our team had seen and heard. I think the feedback took a long time. The trust were seeking to find out what actions we wanted them to take. And I have to say it's one of the worst inspections that I've ever been to. I drove home and wanted to drive back again in my nurse's uniform to sort it out as a professional nurse. There are a number of areas that we found inadequate. In A&E, we found that there weren't the paediatric nurses on duty. The Trust had one permanent member of staff and one supernumerary member of staff to care for children in A&E. They had a service level agreement with a provider trust of children's services, but there was no cover for children that would come in at any time of day and night. There were also issues with access to medications, so doors to medication rooms were left open. Patients and staff would have had access to muscle relaxants. And despite being told on day one, they were still open on day two. In surgery, we had reports from the ward that Jonathan highlighted around the length of time that nurses took to answer call bells. And one patient reported to us that they had been told to soil the bed and nursing staff would clear it up afterwards because they couldn't get there in time. We've since had a further whistleblowing on this issue. I've talked about the experiences in the medical ward. It was particularly on Appletree ward, but other instances were found throughout the medical unit. So therefore, as Mike has explained, I contacted Mike. We had an urgent management review meeting on the Friday, at which point it was decided to send the Trust what is called a Jane letter, which is saying if you don't take action, we will take action to reduce the number of beds you have on the ward. They took that action, but as you can imagine, the conversation continued over the following weeks.
Thank you very much, Fiona. Mike, do you want to just say anything after that, or should we just open it up for discussion?
I think we can open it up, to be honest. David?
Okay, yeah.
I mean, my first question is, what's it like now? I mean, have they made improvements? You know, because if patients were suffering, you know, I'd kind of like to know that it has changed and it's improved and that patients are sort of safe.
Yeah, absolutely. So we had discussions until late on Friday evening about numbers of beds and what they were doing at the Trust. On Sunday, myself and 3 colleagues went back to the Trust. We didn't announce our presence. We sat in a bay, in 3 different bays, and observed practices. Staff were much more emotionally supportive towards patients. We managed to speak to a patient that had been there and we'd spoken to previously on the Thursday, who told us, I don't know what you did, but whatever you did, it's much better now. We hadn't realised it was so bad until you did something. So yes, patients are.
And we've been back on the second.
And we've been back again. Sorry, we went back. We went back on the Sunday after the inspection on the 21st of September. We went back again on the 28th of September in an evening to check night staff practices, and we went back on the 2nd of January of this year.
Can I just add to that? I think on the 2nd of January, I think the improvements in medical care had been maintained, but there were still very considerable concerns about the A&E.
Could I ask you just for a little more detail about what you say what the issues you found on Appletree Ward and the extent to which you found similar or other issues on other wards? In other words, is what we're talking about just in one place, two places, or a number of places? And then finally, just so I don't have to ask a series of questions, you've talked about the governance and who is being held to account or not, and the uncertainty about that. But at what level, if at all, did you find any awareness of the problems above an individual patient's problems that you've described?
Okay, so the team went in at 7 a.m. on Thursday, and they sat in a bay. They witnessed a patient who was asleep. A nurse came in, drew the curtains, and the first words they uttered to the patient was, "Roll on your side." And the patient woke up and said, "Who are you and what are you doing?" And the nurse said, "Roll on your side, I'm going to wash you." And so one presumes the patient complied, and was then told to roll on her other side. And patient said something along the lines of, "I don't feel quite clean." And the nurse is heard to say, "Roll on your other side." Patient obviously complies, and the next thing that is heard is, "Ouch, ouch, you're hurting me." The curtains are pulled back, and the patient is quite obviously distressed. The team also witnessed a nurse standing above a patient about to give them breakfast, saying, "Don't misbehave, you know what happens when you misbehave." They observed and heard patients from either side of the bay talking to one another. One patient said, "They woke me up all night pinching my bottom." And we also witnessed another unsafe manoeuvre in moving and handling practice.
But in terms of was it located only on Appletree Ward, or was it in other places? My understanding of that is Appletree was the worst, but that there were other medical wards where the care was certainly not good, and in addition to that, the call bell issues and the patient being advised to saw the bed, I think, were on surgical wards as well.
Yes, it was on. The trust had previously had an issue in the summer with a ward called Juniper Ward, where a patient had complained and they'd investigated, and they had taken remedial action. However, at our inspection in September, we found that patients were still concerned about the length of time that it was taking to get call bells answered, to obtain pain relief, and to be able to get a drink. So it was predominantly apple and juniper, but minor other issues were found on other wards. I'll let you order.
Thank you. As Fiona said, it was in more than one area. Having said that, there were some very good areas. Critical care, particularly in a smaller unit, which is quite difficult in critical care to maintain, it was good. Maternity, again, good across the board, some very good practice and some innovative practice. So there were some areas of good practice, but it was why the problems were widespread enough in medicine and in some of the surgical areas for all the concerns to be highlighted, as you've heard. I think, as I alluded to earlier, the nursing voice in particular, what didn't seem to get through. The Stop the Line initiative, when it was called, which effectively we called, having brought up the issue with the Chief Executive directly, the response that was witnessed to that was not one of appreciative inquiry, but rather than where could we find some blame, rather than solving the issue, which was a concern, it was felt that people did not feel that, although it was when we first heard about it, we thought it was an excellent idea, one even that should have a wider spread use. But as ever, ideas, it's the application of the idea. And there were several instances of staff showing that they did not feel it was a safe thing to do to bring forward those concerns. Undoubtedly, a significant number of passionate clinical leaders, but virtually all of them that we talked to showed that they were stretched to deliver what they were needing to. Some of them were quite inexperienced. Not that all of us have to start at some stage, but they were stretched and to some extent inexperienced for what they were being asked to do. So the passion was there, but the actual resource and facility to deliver the governance and cross-cutting aspects. And unless you have that good balance between medical, nursing and managerial triangulation, you can so often miss things in governance. Then you need your further triangulation. It was absolutely clear that the committee that they said did the challenge wasn't as informed as it needed to be, and the level of challenge was not what you would expect in a constructive governance mechanism for that. And it was deeply unclear, despite several requests for clarification at the board level or franchise level of challenge. And I think that came through, particularly the example that Juniper had problems about 3 months beforehand, and having raised an issue in one area, one would have expected the organisation to look wider, to say, is this possibly a problem we have elsewhere? And that clearly hadn't happened, and the ward pressures, i.e. keeping up the number of beds in the ward over the number of spaces available, had beds in the rehabilitation area, which is rehabilitation, as we know, is a key part of gaining more rapid recovery, and particularly the elderly care grouping. That pressure was maintained rather than relieved, and looking at supporting staff to enable the care, quality of care they wanted for patients.
I just wondering, can you remind the board how many wards there are in Hinchinbrook Medical and Surgical, and how that compares to a standard DGH?
There are approximately 8 wards, 10 warded areas, and that is a reasonably small DGH.
To give a sense, there's Appletree ward as a medical. How many other roughly medical wards are there? I think it's a very small number.
And
so your point about
and the total number of beds is just over 300, which, by the standards of district general hospitals in this country, is very small.
And the point you're making, Paul, is that this is one ward is a big proportion of the total number of medical beds, I think.
5.
Thanks. So can I ask about the some of the information that you had around the inspection? So I'm struck by the fact that you said that this was a hospital that was in band 6 from our monitoring. So there's an obvious mismatch between going from band 6 to being recommended for special measures within a couple of months. So I just want to understand what it was that you saw as the difference between those two things. And I suppose I'm thinking in particular of whether, I'm sorry if you already said this, but I missed it, whether there was evidence from patient complaints as well as from the data that could have alerted us to what had happened, and that perhaps would corroborate what you observed and make it sound, tell us whether it was more widespread. I suppose there's an equivalent question about staffing levels. Did we know anything about staffing levels before we went there? What were the staffing levels? So it's just putting the data, the observations that you found alongside the other available data, and to try to understand the complete picture. I've got a supplementary question, if that's all right, and that's I'm trying to understand the length of the process. All of what you described happened in September. What happened from September? I just need to understand why we are now in January talking about that trust being recommended for special measures when the inspections were 4 months ago.
Shall I start off on both the inspection, the intelligent monitoring, and then the timeline? we've always said, as you know, Lewis, that with intelligent monitoring, it is a screening test for a trust. We do not expect it to be totally accurate. If it was totally accurate, we wouldn't need to inspect. So that's the first point. And as you will also know, subsequent to the trusts that were put in special measures following the Keogh review, there were 11 of those, we as CQC have put 8 trusts now into special measures, some of which were high risk in terms of our banding, but others were not. So this is not unique. And Queen Elizabeth King's Lynn was not particularly high on risk banding, nor was East Kent, for example. So I think what we have seen is that in general, and this is not again exclusively the case, those trusts that are in a high risk band do tend to have quite a lot of problems. There are exceptions to that. But that's why we have been prioritising those ones for inspection, largely. So I think the answer is, I'm sure intelligent monitoring will get better over time as we get more and more intelligence, but we will never expect it, in my view, to be fully accurate. And you will know that I sent board members, I think just before Christmas, a paper on why we needed inspection as well as an intelligent monitoring, and how the two complement each other. In terms of the timeline, the timeline was... It inevitably, as you know, takes a couple of months to get to the full report stage, and it was because of that we wrote the letters of concern, the Jane letter and then my letter a week later, outlining our overall concerns about the trust, in order that things could start being put right as soon as possible, so that we knew that they had heard what we were doing. The timeline was that we got a large number of factual accuracy comments. And we wanted to make absolutely sure that we had addressed all of those. That took time, and so because we knew that they were already in position of our views on the key headlines, we took time deliberately to get this right, and then Christmas was there, but so we issued the report very early in the new year.
And also, Lewis raised the staffing levels issues.
Shall I? And just following on from that, with the greatest will in the world, data cannot give you a picture of the culture of a place and the behaviours of staff within that place. So a lot of the issues that we found were around accepted cultures, leaving doors open, behaviours of nursing staff, and the data can't always pick that up for you. We did attend a Health Watch event about 10 days prior to the inspection, where we heard a mixed bag of experiences about the hospital. Most people said generally it's okay. There are 1 or 2 wards that are not great, but other than that, it's okay. So our findings kind of reflect that, I feel. Staffing levels. The Trust had undertaken a staffing review. Like every other trust in the country, it is difficult to get staff. They have been out to the other countries to find staff. They used quite a lot of agency staff, not significant numbers, but a number of agency staff, and they have a pool of nursing staff where staff can opt to work 2 or 3 shifts a week, or they can work extra shifts to their normal duties.
I think the other aspect on staffing is not just staff numbers, it's the appropriate staff with appropriate training in the appropriate areas. And so for an emergency department, all emergency departments are challenged at the moment, as we know, but for small departments it's very difficult, particularly to keep up the skills you need around paediatrics, for example, for that, and you need that. Children do go off very quickly in an emergency department. You need that skill set to be able to pick that up. Maintaining that in a small department is very, very difficult, and they were very challenged around that. In that particular area, maintaining the your numbers when the surge of admissions goes up, again, is challenging in a small organisation. But at times you need to say, actually, we need to be working with others rather than just trying to pack as many patients into a ward as we can.
Do you Do you mind if I just follow that up? That's very helpful. I wasn't particularly implying that the intelligent monitoring was right and somehow the inspection was wrong. But obviously there is a need to understand how they relate to each other. Particularly as your conclusion in the end was that safety, I'm thinking of particularly, was so compromised that the rating should be inadequate for safety. I think I'm right in saying in two clinical areas, and that presumably had a very powerful impact on the overall rating. And so I'm just want to make sure that we have a sort of valid and I suppose reproducible way of identifying safety which is so inadequate that it has these serious consequences. And you've talked very graphically, I think, about what sound like some terrible aspects of care, lacking the proper standards of compassion and concern that people should show towards patients. I just need to be clear that it was also unsafe. If the intelligent monitoring was not telling us anything about safety that we should have been worried about, and if there was nothing remarkable about staffing levels, and I suppose also about patient complaints. I don't think you answered my point about whether did they have more complaints in this trust than usual? Did they manage them badly? Did any of the complaints say any of the things that you found? So, just understanding how we got to the point where the rating was as bad as it was, particularly on safety. Was it? I mean, did we see anybody actually harmed, as opposed to treated poorly?
I'll leave Fiona talking about the issue of whether we saw people being harmed. In fact, I think she's already alluded to a case on Appletree Ward. I think it is important to know what we do get from intelligent monitoring on safety and what we don't get. And again, I'll refer you back to the note that I circulated on this. So we do have information on incidents, the numbers of incidents, and we can look at that in comparison with the size of the hospital. But of course, what we don't really know until we get on site is whether they are very active reporters of incidents. In fact, high levels of incidents, maybe reporting may be a very good thing. And we talked in our focus groups to junior doctors, to junior nurses, etc., about incident reporting. And that you have to take those two in conjunction. And when you hear, I'm not saying about this trust, but when you hear in trusts, we've stopped bothering to report incidents because nobody comes back to us on that, which is what we do quite often here, then we can interpret what we've read about incidents. Equally, on cleanliness and infection control, clearly we have information on C. diff and MRSA before we go in, but we know the whole country has thankfully got better at that. But what we can't tell till we go in is about hand washing and whether gels are available and things like that. Equally, in terms of medicines management, as Fiona said, doors being left open or whatever, records management, all of those things. And although probably we could pick up mandatory training before we go in, we're not at the moment. So we ask about that when we're on site. So there are a whole range of different things that we look at and we always report on, and they're under our subheadings for safety, that we can only tell when we go on site, which is one of the reasons I think that we will find other places that are not good on safety that haven't necessarily come up in intelligent monitoring.
As to whether we saw anybody harmed, no, I don't think we saw anybody harmed. What we did see is that pressure care was not in line with NICE guidance. There was a lack of monitoring of pressure areas. IV cannulation was also not in line with NICE guidance. We saw that equipment wasn't always well labelled. We saw that there were some significant issues raised around mental capacity of patients. And the report highlights an area where a patient was given some sedation with no documentation around an assessment of capacity in that case. The doctor says the assessment took place, it just wasn't documented. So yes, we didn't actually see patients being harmed, but the potential was there.
I don't want to get too hung up on whether you actually observe something harm, but you give graphic examples of what you did observe. So I was drawing a distinction between what is poor care and what is actually unsafe. It sounds to me as if you had quite a lot of information suggesting that safety was compromised. The issue is here is one of calibration. Nobody is saying that you have got a trust there which was safe and you called it unsafe. The question is, how do you get to the point where this is at the extreme end of safety? That's what I'm trying to understand. But I don't want to labour that point. I think you've explained how you came to that conclusion.
A sort of comment, just thinking of safety and thinking of data. Because when you get the data through that might show there's a problem, harm has already occurred. So I think there is an argument for, what we really want to do is to sort of nip it in the bud and respond quickly. Otherwise, we get the likes of mid-staffs. I mean, that's an extreme case. So I think there's an argument for being quite firm and responsive to potential safety issues, because, otherwise we don't want to wait a year until the data shows us there's a problem, because people will be harmed. It's a difficult balance, but I think particularly with safety, we should, not be afraid of being quite firm about that, because we actually want to prevent harm, really, rather than sort of find it, if you like. The question I wanted to ask, you've answered it a little bit, but there's been, as you know, sort of allegations of bias, and the Daily Mail have been quite vocal, shall we say. Could you just say a little bit more how you made sure that the way that the inspection at Hinchingbrooke was conducted was similar to other inspections, so that there was kind of consistency in approach? Thanks.
Shall I start off on that? I'll just briefly on the safety point first, just as a sort of reminder that we do have specific key lines of inquiry related to safety, and they relate both to past harm and to current or future harm. And equally, going back to your point, Lewis, that the provider handbook actually sets out the characteristics that would be needed to be declared inadequate. And part of the consistency, well, there are a number of things about consistency. First of all, it's recruiting good teams and making sure that the training is there. And remember that, Fiona was mentioning how many inspections she's now done, but also a lot of our inspectors have now done multiple inspections. So that brings consistency, because they've seen a whole lot of other places, and they've had more training now than they would have done a year or so ago. Plus, a lot of our external experts have actually been on multiple inspections as well. So it's training, it's selection. It's then also about the corroboration sessions on site, where there is challenge. Way back, I remember there was challenge about a hospital we visited in the first wave, where there had been some never events, which were obviously passed. They had said that they had now got on top of it, and the team on site had said actually they're now doing the WHO checklist properly, which they hadn't been doing. But so how do we call that one? Because as of the day when we were on site, it looked all right, but that was passed, and we felt we really couldn't give that a rating of good without more evidence that over time it was going to be good. But I can assure you that almost the final step in this is the National Quality Assurance Group. And remember, those are always chaired either by myself or by one of my deputies. In this case, it was Ellen Armistead. Again, we have seen a lot of these inspections now, and so we are looking for consistency. We always have people from intelligence there. We always have people from policy, as well as the inspection team as well. And when we are considering giving an inadequate rating, that's any one of those cells, not just the overall inadequate rating. Each of those inadequate ratings is considered in great detail with the provider handbook to our side, and we will actually read out what are the characteristics that you would need to be deemed inadequate. And we will have done that, because we always do.
It's just a couple of questions. The first one is specifically on the paediatric cover in A&E. Is that now better? Is one question, and also the level of paediatric cover that we felt was appropriate or inappropriate. Is that our normative? Is that our normative assessment, or is that coming from the Royal College of Paediatrics, for example? So that's question number one. Question number two, I don't know whether you can answer this, but in assessing the culture of the place, and in particular the well-ledness, it strikes me there's sort of three big groups at play here. One is staff, one is sort of clinical staff, one is management of Hinchingbrook, and the other is Circle itself. And I don't know whether you were able to draw any conclusions about, you've talked about the relationships, I think, between staff and management, whether you were able to, in your investigations, you heard anything about Circle itself and whether or not they had any, what their impact was on the culture of the place outside, coming from, if you like, outside.
Well, the paediatrics issue, the College of Paediatricians and Child Health and the RCN issued guidelines back in 2003 about how many paediatric nurses should be on duty in a A&E department, which was essentially one per shift as a bare minimum. As I say, we found one member of staff working 37.5 hours a week and one supernumerary member of staff. The Trust has now managed, the Trust took initial action of employing agency paediatric nurses to support its permanent staff. It has now managed to recruit, and by the end of February they will have 3 whole-time equivalent paediatric nurses in place. They do have a service level agreement with the Trust that provides paediatric services at Hinchingbrook, which they are currently reviewing because it was inadequate for what they needed at that time. So paediatrics at the moment is covered. In respect of culture management, it's an interesting one. We didn't seek to ask questions about Circle because Circle was the management element of the Trust, the financial element, and that's not something that we particularly look at. So we didn't actively seek to ask staff or patients about the Circle element of care. Obviously, some staff volunteered that information, and it was a mixed bag. So I think there was a recognition that Circle had invested in the hospital and had refurbished different areas within the hospital, but it wasn't something that we were particularly questioning.
Just to add to that, I think it wasn't really an issue of who was running it, it was how it was being run, the lack of governance over it, the lack of challenge, which allowed issues not to be picked up and then sorted within the organisation, and the fact that significant numbers of staff did not feel that they could appropriately escalate in a speedy and timely manner and get things then resolved. And those two issues coming together, to some extent, it's relatively relevant who was doing it, it was how it was being done for that. Dave, there was a question over from Kay about the bias and the comments. Do you want me to explicitly come back on those? So there has been comments related to explicitly myself, one other member of the team, back to comments I made back in 2007-8, I believe, in the public domain. Those were, 7-8 is quite a long time ago. At the time in 2007-8, I was in active private practice, undertaking private practice. So to say I was anti-private practice, I think, was incorrect. They're related to mass privatisation rather than work in a particular area. Shortly thereafter from that, I worked very closely in my trust in the Royal Berkshire with a private sector organisation on the outsourcing of pharmacy successfully. In my current organisation, I sit on the board of a joint venture with a private sector organisation for pathology, and we also work very closely with a private sector organisation, Healthcare at Home, in UCLH at Home, caring for patients. So I think, certainly from my own perspective, it is a matter of how do we care appropriately in a high-quality way for patients. It's relatively relevant who, it's how. We do that in getting high-quality care for patients. There was a challenge within the group to make sure that we were, across the group, consistent for that. So I hope that answers that question.
Can I just add to that? It was, as Jonathan keeps saying, it wasn't for us about who manages the trust. It was around how it was managed. There were no discussions around Circle being involved. The private sector was barely mentioned. And within the teams, they are teams, and everybody plays a contributing part, and everybody agrees the judgment at the end of the day. It's not one person.
Okay, well, look, Jonathan, Fiona, thank you both very much for coming. We're just going to have a quick talk about sort of conflicts of interest and how we raise them and stuff. So do stay for that. Just if you've got another 10 minutes or so. David, do you just want to kick off this discussion?
So I think the other question that I think falls out of Kay's question and Jonathan and Fiona have just come on to, that was raised by the media, was this issue about people's backgrounds and what checks. And we've had a discussion now going back to last autumn for both staff of CQC and for ourselves as a board about conflicts of interest. And I think we're actively considering that. And we've agreed an approach for staff, which we will review in the light of the past few days. But on this particular inspection, every single member of that inspection team, and Mike has run through the numbers and the backgrounds, and Jonathan and Fiona have said, were asked questions consistent with that conflict of interest policy that was agreed in the autumn, which was largely about your background, your connections, your family membership, financial interests. The issue that was raised about, did we ask about any other declarations, and I say declarations that people would want to make about groups or bodies that people may be a member of, and whether that should influence this in any way. So, David, we'd asked Sandy to look at this from the perspective of the board secretary's role, the company secretary role, with a view to the report coming back. And I'll ask Sandy just to say a little bit about that, but also Tracy Dennison, who's our head of HR, has been doing some work in relation to the questions raised from last week about whether there's an additional question we would want to ask about conflicts of interest in the light of this, which allows a declaration to be made by people, so that's clear and transparent. The trust are aware, any trust that we inspect are aware of who the inspectors are. That's part of the information that they're provided up front and in advance. But if we just describe, if I invite Sandy just to describe the wider review, and then Tracy will just say one or two things about the way we've actually refashioned the declarations for our inspections pending an outcome of this more formal and larger piece of work, which will come back to the board in February. Sandy.
Thank you very much, Chair and Chief Executive. The board members will be aware that there was the discussion at the December board of what was a draft paper on declaration of conflict of interest for board members, and that a decision was taken that that matter should come back to the next board meeting, the February board meeting, with a revised paper, and work on that is ongoing. Obviously, there have been these developments that have been referred to in the meanwhile. The staff, there are three separate, if you will, categories of declaration and conflict of interest policy. One for staff, one for the board members, and then, as we've been discussing, those for inspectors, advisors, experts by experience and so forth. And what we want to do is to broaden out our work on this to make sure that there's consistency where there should be consistency. across those three different categories of people who need to declare interests, and also that we've got a proper taxonomy of the types of interests needing declaring, as the Chief Executive already explained, relationships, financial involvements, but also other memberships, involvements or interests that should be declared, so that the CQC can look at those and satisfy itself that those involvements would also be acceptable or not. And work is ongoing on that, and we would be intending to bring that paper back to the February board. So I hope that answers the question. Thank you.
Thank you, Sandy, for that. Tracy.
Thank you. Just to add, so while that review is ongoing, to pick up the learning from this case, we will be, in the meantime, sending out a revised declaration of interest form to all CQC staff and to clinical advisors who are booked onto forthcoming inspections. And that revised form will include a specific question asking them to declare other interests or involvements that CQC should be aware of. And in the examples of potential conflicts of interest that we include with that declaration, we will include two examples, and these are suggestions that Michael Meyer has made. And those two examples of potential conflicts will be membership of organisations which campaign on health, mental health and social care issues, or membership of bodies which represent the users of services the CQC regulates. So that's an interim process we're going to put in place immediately whilst the more formal policy is being reviewed.
Right, well, that's going to come back to the board in the February meeting for more detailed discussion. Robert, did you want to...
Just a question, really. We've been told, and I think I knew anyway, that the inspected body is told who's the inspection team are in advance. Do they have any opportunity to, or even if they don't think they do they ever object to anyone participating in an inspection?
I'm not aware of any trust ever having objected to an individual, but certainly if they did, we would consider that, and I would expect the head of inspection then to contact me or one of my deputies if I'm not around, so that we would have an urgent conversation about whether we thought that was a reasonable approach, and whether we could be in any way open to a charge of bias if they did that, if they continued on the inspection.
Did that come up at all in the inspection, Jonathan, or not? Was there any issues raised about any of the inspectors?
From recollection, not directly at the beginning or during, no.
Good, well, look...
I just sort of feeling slightly uncomfortable. I mean, there's lots of great doctors in the NHS who have very strong views about how the NHS should be run, and I think if we were to leave all of them out of our inspections, we wouldn't be anybody left. So, it's just when you said, Tracy, about people who are members of campaigning groups, mental health campaigning groups. I mean, can I just check that what you're saying is that we just need transparency? We're not trying to veto people. Yeah.
Very important that the policy and the message we want to get across to people is declare everything. But that doesn't mean to say that everything, and the policy does go into this in some detail. You know, it doesn't mean to say that everything is a conflict of interest with CQC's business. But it's in the interest of transparency. We want people to declare things so that we can then resolve any conflicts which do exist, but they may not be a conflict at all.
And can I just ask Jonathan maybe one last question on this, because I mean, I don't know how you said this was your first inspection. And obviously, as we said, nobody was expecting it to be quite as difficult as it became. And I wonder how actually you felt about being in that situation. And also, I wonder if I could ask you a specific question that has come up in the press about alleged conversations with a paediatrician, which are said to have influenced the section of the report on paediatric services in A&E. And you know, again, that's the classic kind of thing where it'd be very useful for us to know, were there conversations of that kind? Was undue influence given to that person? And were any of you aware of that person's particular conflict of interest?
So on the first question, I think we were initially expecting that this to be relatively straightforward, but clearly took it very seriously, but focused, as I've said earlier, on what was right to get the quality care for patients. Subsequent to that and the subsequent period of time, I suppose I'm relatively fortunate in having a thick skin and 6 years of board level experience, including public boards, and therefore I've built up a degree of resilience for that. I suspect there may be others and who are wondering around if this is what happens to chairs or inspectors who do this largely semi-voluntarily. There's a slight recompense for it, but that might begin to question. From a personal perspective, I'm relatively thick-skinned, and it goes with this type of territory, I think. But I think we need to be mindful of the support necessary about allowing people to focus on getting high-quality care for patients. From my perspective, on the specific question about the paediatrician, I don't recall there being that particular bias, but Fiona?
No, the paediatrician was just a paediatrician that we happened to speak to. He wasn't targeted by our staff. We would naturally speak to, we spoke to 246 members of staff at the Trust. So he was just one of those 246. And anybody that we speak to, we would then seek to triangulate their evidence with other pieces of evidence. So a single comment wouldn't necessarily trigger a comment in the report.
That's great, but in that particular, just to be really clear, I mean, you're saying here there was only one, there wasn't a series of meetings with that person?
There was an interview with that person.
Right. One interview with that person as part of the process?
Absolutely.
As part of the normal process?
Yes.
Yeah. Okay.
Look, Jonathan and Fiona, can I thank you both very much for coming today, and thank you for doing and being part of what has been a pretty difficult time for you both. But you've done an extremely good report, and I mean, I think it is just worth reiterating that we're not interested in ownership, whether it's private, public, mutuals, employee ownership, or anything else. We're interested in what's right for patients, and that clearly was both your focus on this. So thank you both very much. Thanks. Right, should we carry on with your report, please?
Thank you. This is largely an update report, David. So I'm giving an update on recruitment and the progress that is being made. If you recall, we're looking to recruit up to 600 additional inspectors in two groups of up to 300 by the end of April. And as of last Friday, at the time of writing this report, it was 106 successful offers have been made. I think by Friday it had been gone up to 111 and continues. This week we opened recruitment in relation to inspection managers, and in light of some of the comments, we are having a fast track for internal candidates to actually make rapid progress on that process, and we've also begun campaigns in relation to the recruitment of analysts. In paragraph 2, I'm just updating the board on the development point that Jonathan, I think, was making about the importance of developing staff. So we've got 4 courses being run through the new education and development and learning management system that is now in place and up and running in relation to mental capacity enforcement, fit and proper person, and duty of candour learning. And I think that's good progress being made, but the numbers in those paragraphs give you a sense of what still has to be achieved to get all of our inspectors good to go. I've then got updates from 3 inspection directorates from Andrea, and I think it's probably worth just dwelling on this. There's some numbers in there in terms of the number of rating inspections and just the distribution of those rating inspections. But David, who's a member of the public, who's a regular attendance at this board, has been in correspondence with members of the board on the surveillance. So maybe, Andrea, if you just want to update us on where we are on surveillance and the report for the public about surveillance.
Yes, thank you, David. As you know from the report, the information for providers has been published and has been quietly but well received, which I think is good. Secondly, on the public information, we have, following on from the last conversation that we've had lots of helpful comments, and Camilla in particular kick-started us off in a much better direction in the way that information was being presented. We have, I think we've pretty much come to the end of the road now. We've had continued comments from others, including David, but others. We took it to our Experts by Experience group. We've taken it to our public online forum. You know, there's been a variety of things that we've done to test it. There's been some final commentary over the weekend. I can share directly with those board members who have been involved in it how we're dealing with those specific comments. Many of them we've taken on board. Some, you know, we've had to tweak a little bit in consideration of some of the legal issues and the views from the Information Commissioner's Office. But I think that we're there now, and it's already once been to the Plain English campaign, who had approved it. It will go back now on the back of the further changes that we've made, and it will go to David with mine and Paul's recommendation that we publish it, and we'll kind of timetable that for when that's appropriate.
And I think we've covered Mike's update report in the last discussion, and there's an update just in terms of the progress in relation to acute ambulance trust, and indeed resonant with the last discussion, piloting the inspections of the independent sector hospitals that we're taking forward. Update reports on the progress that Steve and colleagues are making in the Primary Medical Services Directorate on primary medical services, but also this work that we do with criminal justice inspectorates, largely around people who are receiving healthcare whilst also receiving criminal justice services, whether that's prison or probation services. Following Alexis Jay's report about safeguarding, but also connected to some of the high-profile cases on Savile, Rotherham and Manchester, Secretary of State wrote to us in January in relation to what work we were undertaking in relation to children's safeguarding. So I've responded to the Secretary of State in that letter, and there's 4 bullet points on page 6 which are extracted from that letter, I think, to give the board a flavour of the work that we undertake in relation to children's safeguarding. Alexis Jay's report didn't really focus on the healthcare dimension of what was going on in the services that she was asked to examine, but we've considered that report. We've met with Alexis Jay. We have a couple of specialist advisors who are assisting in this, a clinician and a former director of children's services who has a long background and experience in this, is assisting us with this, and we are working with NHS England and the Criminal Justice and Children's Inspectorates Ofsted in relation to how we can take that work forward. So this is work in progress and is an information report. Health and Social Care Information Centre have published a code of practice on confidential information. They're in a set standards, and we work within those. So we are currently reviewing our own code of practice on confidential and personal information, which we'll bring forward. NHS trusts are are considered as part of the Counter-Terrorism and Security Bill about the requirement on certain bodies to have regard to the need to prevent people from being drawn into terrorism, and I just draw attention to this. The government's response to Sir Robert's report is anticipated in February. Parliament is in recess from the 12th to the 23rd of February, so I think there's a clue in there somewhere of when in February it's likely to be. And then the last item we're drawing attention to is, David, you and I went to meet the Committee of Health Watch England, and I was given a briefing note which captures some of the more detailed and granular work which is being undertaken between CQC and Healthwatch England, and what you've got on page 8 of that is that briefing note just extracted in its entirety, which says what's working well locally and nationally, what we need to do more on. And I think as Chairman is not here, but as Anna said, 12 months ago we wouldn't have been able to produce that report saying what arrangements are in place and how that is working. And whilst there's more to do, I think what this does demonstrate is that there's a very practical working relationship between local health watches and CQC, and we're trying to capture that in this report. So that's the report, David. Thanks.
Any question for David on the report? Your report? Camilla?
Just one tiny point on safeguarding, and I agree with you. I mean, Alexis J that wasn't her. I'm not quite sure why. Anyway, but it's fine. I mean, she wasn't looking at health. It just strikes me that in all this, lovely liaison with lots and lots of people, the one thing that would make a big difference is if GPs regularly examined children properly. Do you see what I mean, Steve? I mean, and maybe children in care, or specifically children at risk. But we don't in this country do what they do in other countries, which is we have at regular intervals a proper examination of the child without their clothes on. And I just can't help thinking that that might help. Because you can have all the partnership working meetings you want, but if you want to get at some of that, maybe? I don't know, just a thought. Or health, exactly, sorry, it doesn't have to be GPs.
That's true, but if we are concerned about child abuse in a reactive sense, the way you examine a child is to undress them and check their whole body. That should be standard procedure for all GPs.
But it's not. It's just not. And we don't. That's just not what happens. That's all I'm saying. Is that's not what happens.
Yeah,
so,
it should be. You're right.
But it's not.
Yeah. But you agree with that,
we
Steve?
we can make a big difference, Steve, if we pointed that out.
Well, my responsibility is for child safeguarding as part of the directorate, so we'll take that back and actually we'll talk about it as well.
I think the issue of what role people play. So I don't. We haven't got enough people just to go to meetings for meetings' sake. Just on that liaison point. So that's the point about always beginning these with what we need to do to recruit people, just to do the work we've just been speaking about. I think. Alexis didn't do that. I think that's why the Secretary of State wrote to, not just to us, but to other people to say, what are you doing about this? This is it. I think for a long time, the issue of the roles of different bits of the healthcare system in relation to safeguarding has been pointed out. I think the tricky bit on this, Camilla, is I think what Jay and the Rotherham and Manchester reports were about is really young adults or teenagers and adolescents, and I think that raises a whole bunch of issues about how that is done. And I think a lot of the stuff, going back to when I was the Director of Social Services and Children Looked After, there's big issues about 14-year-olds getting undressed in front of anybody. So I think there's some really difficult issues at the bottom of this. I think what we're attempting to do, and I think Steve and Sue Macmillan, who I have to say I think does this work very, very well on our behalf, with a good deal of proportionality, it is really about what is the role that we need to play, and our job about encouraging improvement. Can we contribute? And a lot of this work is largely done with the Criminal Justice Inspectorates at Ofsted. Can we play a role in this, which actually raises some of the key health-related issues which will lead to those improvements? And I know this is something that you've, have looked at and studied and probably know as much as any journalist, and it is a key issue for us. And we need to continue to work at getting this right, and I think that's what we're attempting to do through this. But it's tough. Because you can't regulate quality into services. It's got to be there, and the only thing we can do is assess whether it is there.
Yeah, but that's if we assess that it's not, if we show that it's not there, that could be in itself. Yes, and I think that's what
Will you take that away? And
yeah, I think it's really important.
Yeah,
see what we can do.
Okay, thanks.
Apologies, first of all, because I'm going to raise the issue of the surveillance leaflet. And I know that it's just Andrea's section of your report. It is interesting. I mean, I think this is I'm slightly sorry that we've got to the point we've got where it feels a little bit as if the concerns that people have had about it have gone from being sort of insightful and helpful to being just a little bit tiresome because they keep making them. And I just wanted to reflect on two things. One is the content of where we are with this, the leaflet for relatives. And the second thing, just about our own process in getting there. It has been quite difficult. It's a subject that's attracted a lot of public interest. And I do think Andrea's had a very difficult task in trying to steer a sensible ground between different views. I understand that completely, and so I have a lot of sympathy, Andrea, for the position you're in, starting with your initial appointment when you were sounded quite positive about the role of covert surveillance, and then it feels as if there have been increasing impediments in the way of doing what seemed like a popular thing, to the point where we finally at the weekend was circulated a much better draft, I must say, a much better draft of a leaflet than we'd had previously, but one which still felt a little bit like there were a lot of impediments that you members of the public are going to really struggle to get through. That still felt like the tone of it, and with the implied message, I think that this leaflet was about to go to press, and that it was going to be it wasn't even time for board sign-off because it was so important to get it off to press. But we've been talking about it for months. So I'm slightly perturbed that comments about it, about these impediments that seem to have been put in the way of concerned families, have gone from being important and something that we must respond to being just a little bit of a problem in their own right, that people still hold this view. And we've got to get around that. And later on when we talk in the rest of this meeting about the Mental Health Act report, I'm going to make the same point, that our process is getting to the point where board sign-off has become too perfunctory, too forced, and with not enough time. Suddenly the message is, we've got to get this out straight away. Can we get your sign-off even before we have the meeting? And we can't operate like that, I feel. So on the leaflet itself, why am I still going on about it? I think it is a lot better. But for those members of the board who didn't have time to read it when it came round the other day, it still says that if you're a worried family member, then let's remember this is about families who've got somebody who's usually suffering from dementia. That's going to be the usual situation. So they're going to be in a care home with dementia, having difficulty expressing their own concerns about how they're being treated. Family suspicions grow. They're worried about what somebody might have said. They're worried about maybe a mark of bruising or something. So it's a very serious and anxious time for a family. Our leaflet says, make sure that you write down exactly what the person is agreeing to. Make sure you get them to sign it. Don't forget, this is your relative with dementia. Get them to sign your agreement with them about the use of covert cameras. Make sure that you then you tell them all the people who the recording might be shown to. Now, is this really what we expect worried relatives to do? I think that is an unreasonable message to people. That's not to mention the fact that the longest section in the leaflet is the legal section on what the legal ramifications might be, including the staff of the care home may prosecute you. So I think that the process here hasn't been ideal. I can see the difficulties, and this is not a reflection of, and I'm making it clear this is not a reflection of Andrea's efforts, which I admire, and I think it's been a very difficult task. But I do think that we haven't really, unless there is another version that I haven't seen yet, got to the point we should have got to. And that is partly because of there's been something about the inertia of our process which hasn't responded to the first comments that were made about what was needed in this form. And something then about our process which has sort of gone along at a reasonable rate, and then suddenly there's been a need to accelerate to the finishing line over a weekend. So content and process still leaves me a bit concerned. I'm hoping that what Andrea will be able to tell us is that some of the final amendments that were suggested by Camilla, by me, but also by David Hogarth through email, that there is still time for some of those things to be added, or those amendments to be made, and that we will bear this in mind for future process. We can't really be slightly bounced into accepting something because time has run out.
Of all the criticisms about this paper, it being a perfunctory process will be I mean, we have been at this for quite a long time. But I know, understand.
That's my point. We've been at it a long time, and if the changes had been made that were required early, we wouldn't have been at it a long time. You've got cause and effect the wrong way around here. Made my point.
Do you want me to respond? On process, if board members recall, the last fulsome discussion that we had at this was at the November board meeting. And the conclusion of that discussion, which David pulled together, was that we'd had a very full conversation. We'd been given a very clear steer about various aspects that we needed to do, that he asked the board to let Paul and I go away with this. Yes, I've been fronting this up, but it is a policy position for the organisation that impacts across all three sectors. So actually an awful lot of the work has been done by staff within Paul's team, for which I'm very, very grateful. But that we would go away and do that, and that the sign-off would be with David away from the board, and it wasn't going to come back to the board again. So that was the last time that we had a discussion about it here, and that was the agreement. So that's what we've been progressing with. Camilla, very helpfully, and as was suggested at the time, gave us a kind of first draft steer to sort of reshape the document in a way that I think has really helped us to move it forward. We've done further work in terms of testing it with people, and that includes David, who as one member, but there are lots of members of the public who have got an interest in this subject, and not just from the perspective that we should be encouraging the use of cameras, but also from the perspective that we shouldn't. So, there continues to be a range of opinion about what we should be doing in the use of surveillance and the information that we should be providing. So we've continued to do that, and we've continued to reshape the document to try and make it as useful as possible. The reason why we ended up with a weekend flurry was on the back of concerns being raised directly with board members by a member of the public, David, and us responding to that. So, that was a kind of sequence of events. So I think that explains the process point. And I apologise if it looks as if it is becoming, you are, or anybody else is becoming tiresome to us. That is not the case, and I'm sorry if I've ever given that impression. Tiresome is probably not the word I would use. But it, because it has been really difficult, and it's really difficult because everybody's got a variety of opinions to bring to bear on this, and steering that middle course is important. But what we can't do is provide information for the public that says, go out, buy a camera, stick it in there, and everything will be fine.
As if someone is saying that.
No. But I'm just saying we cannot say that. We have to be, but some people do want us to say it, Lewis. I mean, but there are people who want to say, this is completely the wrong thing, and actually you're abrogating responsibilities and making members of the public do your job for you, and that's not the impression that we want to give either. So I think that what we're trying to do is to say these are incredibly difficult situations for individuals, their families. We absolutely understand why you might want to use surveillance, either in the form of camera or audio recording equipment or whatever it may be. We want to hear about care. We want to support you in actually making a difference to improve the care that your loved one or indeed yourself are receiving. And we want to help you to understand how to mitigate any risks that there might be. Because those risks may exist, and it's not kind of theoretical that they exist, they do exist. And so it's in the spirit of trying to be helpful to actually produce this information. We have been able to take on board some of the changes that you, Camilla, and others have suggested over the last few days, and I've got a little table that will explain exactly how we've done that and what we are ending up with. But I think that we have got to get ourselves to a position where we put something out, because that's the commitment that we've made to the public and to providers who are also interested in what it is that we're going to say. But I think most importantly, we made a commitment to share this information, to support people in difficult circumstances, and that is what I want to do.
So I agree completely with Andrea, and she's absolutely right. This is a joint effort. It is worth saying, I think, two extra things. So firstly, we absolutely have taken on board the views expressed by the board and David and others. We've also had to take on board the views of the Information Commissioner's Office, and that includes about the legality of what we are saying. We have a very clear view that we are on the side of people using services. There is a human rights legislation and the Data Protection Act. We can't go outside that in pursuit of our cause. That is the legislation. And it would be incredibly unhelpful if shortly after publishing our information, we were to find the Information Commissioner's Office publishing different information on the same issue because they took issue with what we said in public. That will only confuse people more. We need to make sure that the ground we cover is consistent with their views as well. So, Lewis, you did mention the point of consent explicitly, and clearly that is very important. You're absolutely right. And you probably know this better than I do, the level of mental capacity of lots of people living in residential care, as an example. But again, we have to be very clear with people about what is expected in terms of human rights, in terms of the Data Protection Act, in levels of consent, and the law is the law. We do very explicitly say in that section, if the person does not have the capacity to give their consent, for example, if they're unable to make decisions because they have dementia, it's important that you feel sure that you are acting in their best interest. We do try to cover that point. So this is a tightrope we're trying to walk. We're trying to walk it as well as possible, but we have to stay within the views of the other statutory bodies as well.
Have my 2 cents worth on this. Sorry, I'll be very brief. I have enormous sympathy with all 4 of you because this has really been a very challenging process, and I think basically the board was very clear on what it wanted, and it wanted a middle way, and that is quite hard to achieve in a document. Just one other point that I think, the only reason I wrote that throughout that kind of draft for you, and I'm not remotely precious, I couldn't care less whether you want to use it or not, but the only reason I did that was because we sort of got to a point where we realised we didn't seem to have the capacity here to write a very simple, straightforward document for the public. And we had that discussion about, should we go to which? And that is a worry to me. Because actually, to be quite honest, I don't think Paul and Andrea should be spending their time trying to write an 8-page document for the public. This is not a good use of your time. And I think we need somewhere to find the capacity. And this is, I'm not talking about the content so much, I'm talking about the clarity, because I can see that from the draft, I haven't gone back and compared, I can't remember what I wrote, but I'm very conscious that the draft I wrote has changed a hell of a lot since now, where we've got to. And it's largely changed because of legal conversations and legal issues that have been thrown in. Now, there's a question about emphasis, which both David Hogarth and Lewis have raised, but it actually is less clear than it was. And I don't really mind, I'm actually agnostic on this particular issue. I don't particularly mind how we come out on it as long as we've consulted properly. But what I do think is we should actually be as clear as we can when we are giving advice to the public. And I suppose my reservation about the document, I've agreed with most of the changes that David suggested, as you know, but is that it is not at the end entirely user-friendly. And because it's not user-friendly, it is doing what Lewis is saying, which is it is perhaps more than we intended to, putting people off from using covert surveillance. So I suppose that I'm not being very clear, but my only thought is we just don't seem to have the capacity within the organisation at a lower level, because it shouldn't be, at this level, to just hammer out a really simple draft. And to have that person who can sit there and say, when it all comes back through the machinery and from the Information Commissioner, okay, but let's just think about if you were actually Mrs. Jones, what house is going to help you? Do you know what I mean? And we just need to find that capacity. Sorry, that's all it worries me that we don't seem to have that capacity. I'm sure we have got it. We just need to identify it.
Can I just endorse that? It seems to me that we have a duty to be putting out documentation that that is suitable for the audience that's meant to be receiving it. And our priority is looking after and protecting the patients of healthcare service and adult social care and so on. We all know that underlying our functions and those of the people we regulate is an incredibly complex system of regulation, bureaucracy and so on that very few people, if any, have any understanding of at all in its entirety. I think and anyone who did have an understanding of it in its entirety would be a very sad individual indeed. But we of all people, well, I'll test you one day now. we of all people should have the capacity to explain what the public needs to know in order to go about their business and exercise their rights. And a lot of documents we produce of necessity are not for that audience, they're for politicians and other regulators and so on. But we do, I think, need that capacity, and if we don't have it, we should look for it.
So we do have some capacity. It's limited, but it sits within the engagement area in the editorial and planning team. You would expect me to say this. There are a lot of documents, and we have to target our resources accordingly. And also, it is particularly difficult, even with very good writing, to marry up legal concerns with being really clear.
Tell me about it.
Yeah, there you go. But what I'm hearing is we still need to look at that and see how we can do it better.
So it's a great challenge, and I want to defend some of the people that sweat blood to get things like the State of Care report out, which people commend as being clearly written, well accessed, and the infographics that go along with that. I want to go back to Andrea's point on this. There is division about the policy, and actually the writers can only write when we've got clarity on what it is that we need to be writing, and we've not settled. And one of the ways that I interpret your challenge back, Lewis, is we've still not settled the policy. I'm hearing people saying, I'm still unhappy, not just about the style in which this is said, but the way it's said. So
sorry to interrupt, but my point is that we don't need to have a policy. We need to just inform people of what their position is.
We need a position, Lewis.
Well, the position is that they need to be informed.
We need a position.
And we just, I understand the point about the legal. Honestly, I spend a lot of, you can't escape the Data Protection Act and all the other legal constraints that are around, and the Mental Capacity Act and what it imposes on us all when we're trying to communicate something. But we've just got to look at it from the point of view of the worried family. And being told that you have to get your relative to sign the form, and that you've got, there must be a way of expressing what the legal position is in a way which reflects the Information Commissioner's job. We don't have to do their job for them. We just need to express what they advise, at the same time as giving clear advice. And that clear advice surely is not to say, get your poor relative who you're worried about to sign the form on what you're about to do. Make a list of all the people you might want to show the recording to and make sure they've seen it. I mean, that's not practical advice. That is not what a worried relative is likely to do, and they will just see it as an impediment. Telling them here is what the law, strictly speaking, requires is fine, but explaining to them implying to them that is some sort of requirement is not helpful. And even the phrase "best interests," Paul, I don't think you'd find a lot of people who understood what that means. So it's right that we do say that at the end of the section, I should say. But the issue is not policy. The issue is understanding the people who might want to get something from this leaflet.
What we say at that is that people should get their consent. I mean, the most recent kind of survey that's been done, which was done by HC1, of people who are living in care homes and relatives, showed that people who are living in care homes were less favourable about using cameras than relatives. So that, again, sort of that range of division sort of exists across anybody that we ask. We say that to ask for consent, the absence of an objection is not consent, and that's quite clear. That's what we're trying to be clear about. And we say you can do this by speaking to them, or you can write it down, and you could, and it's couched in terms that actually enables people to make a judgment. And I think that we have been doing this on the basis of thinking through, how would somebody who is worried and concerned go about doing this? What are the issues that they might be thinking about, and how can we support them in taking that through? And the final thing to say is that we have, through the engagement team that Paul has talked about, we have shared this with experts by experience, and we have shared this with our online community. And actually, we've had quite positive feedback, even without the amendments that we've now made in response to the most recent round of conversations. And in fact, one of the things that it was suggested that we take out, which was a very simple explanation about using equipment, that we had lots of positive feedback from people, because again, it helped them in terms of understanding what the situation was. So I think we have tried to take those points of view on board.
But I sort of feel that the board's had almost everything has been said, even if not everyone has quite said it in a sense at the moment. And I think we're going to start going around in circles, and we have got to bring this to a conclusion. I mean, what I'd like to suggest is that, well, to confirm what we said before, that we asked David to sign this off on our behalf, but in doing that, I'd like you to talk again with Lewis and Camilla outside the board. Because there are, I suspect we're never going to get full agreement on this, but I think you were kind enough to say, Lewis, we have come quite a long way, even if we haven't come quite as far as you would like us to come. So and it may be that we can go a little bit further. I don't know, but David, can you take this away? I'm not sure that another board discussion is going to really contribute a lot more, but we do need to bring it to some kind of conclusion. So can I? Yeah. Kindly give this to you, David, and have another chat to Lewis outside the meeting, please. Lewis, you're not being tiresome. This is, don't think you're being. Well, you may be being. You are. No, you are being tiresome. Anything else on David's report? Excellent. Paul and. Oh, Robert, you've got to go. Yes, thanks very much for coming, Robert. I hope your cold gets better.
Yes, thank you. I'll take my
Yeah. Paul.
Thank you. So this is the enforcement policy. It's worth, I think, starting from the position of what's the operating model for the Care Quality Commission, which we've previously discussed, has the 4 components: the registration component, the inspecting, monitoring, inspecting and rating as the second, enforcement as the third, and the independent voice as the fourth. So this is right in the heart of what we do. It's also complemented by the guidance on standards and how to adhere to them, which is also being discussed later on today at the board. Underpinning our approach to enforcement are 2 points. Firstly, that we need to be acting to encourage providers to improve, and secondly, to hold providers to account for what has happened where standards have fallen well below what's acceptable. And that's why we have both civil and criminal sanctions at our disposal. There is a lot that's new in the enforcement policy, reflecting the fact that we are acting under new legislation from April 2015, and to a certain extent we've been doing that already in the case of NHS bodies, but the substantive change is from April 2015. The policy, to give a sense of its progress through, has been through our QC, David Locke, it's been through the Attorney General's Office, it's been through the Department of Health, all of whom are comfortable with it. What we're asking for in terms of sign-off today is the sign-off on the policy itself, which I just distinguish somewhat from the delivery approach and implementation, which I think absolutely needs to come back to the board so the board has assurance on how this policy is being actioned and to what effect. It's a reasonably long document, hopefully not too long. It is important to highlight the decision tree in the appendix, which sets out the 4 steps in the process. which are, to start from the perspective, is the case we're looking at likely or potentially going to lead to enforcement? Because if so, we need to make sure we're collecting evidence to the appropriate standard, and we need to have some form of triage in place at the early stage so that not everything is immediately taken as being an issue of enforcement. We may, in most cases, need to do that discussion through a management review meeting. When we receive information of concern, it is possible that we will be on an inspection when that decision needs to be made. We need to switch into a mode of enforcement where we find serious concerns when we were previously looking more from the lens of is there good care for the comprehensive ratings. So that's the first stage. We then collect the evidence and we have to assess on the incident itself or the facts about the specific potential breach of our standards, whether we think they concerns are serious. And we look at that in terms of the likelihood of them reoccurring, because we want to prevent future harm, and also from the impact if they were to reoccur. That then leads on to consideration of wider factors, the persistence of similar issues in the provider, whether there are a multiplicity of concerns in the provider, and whether we think the provider is able to appropriately respond to the concerns. That may affect up or down the sanctions that we apply, and particularly focus our minds on whether there should be a criminal sanction, a prosecution, for example, or not. Because if we are seeing a significant pattern of behaviour in addition to the individual cause, the individual issue that we're seeing being well below the standards that are expected in law, that would be much more of a case for prosecution. And hopefully, as you see in the paper, there are a number of case studies worked through, both for issues of the future, but also for important cases that we've had to deal with in the past without having this policy, whether that's Winterbourne View or whether that's Orchid View or the case surrounding Mr. Sparrowhawk. And we also, finally, in the steps, need to consider what we call the sector enforcement priorities. This is the opportunity for the board each year through the business plan, which we'll bring back before the beginning of 15-16, to say if there are particular things you would like, we would collectively like inspectors to have particular regard to when they're considering enforcement. That's, I think, the extent to which I should describe the paper. But I did want to labour the point that this has been through some process, including Rebecca and her colleagues, to ensure that it's appropriate legally as well as doable with our inspectors. And I should just finish them up. We've had significant involvement for a number of inspection colleagues, including one of our Deputy Chief Inspectors, Debbie Westhead, but a number of others as well, to make sure that it's practical as well as legally watertight.
Before we open it up, from the doability point, Andrea, so looking at your area probably more than anywhere else, do you feel that this is practicable? Do your people feel that this is practicable?
I think what this is really very helpful is about providing us with a clear structure for the decisions that we need to make, and that, you know, if we go back to the root cause analysis that we had on Orchid View and some of the kind of gaps we had in our process at that stage, which meant that we did not proactively think about what would be the enforcement action on the basis of the concerns that were being raised with us, nor indeed what was the appropriate kind of evidence gathering process that we should be going through. Actually, I think that what this does for us is to give us a much better framework to enable our inspectors to make decisions alongside our legal colleagues, managed by Rebecca's team, in a sensible way. but also to make sure that we don't have to duplicate work because we've got to go back and kind of collect that evidence. And third and finally, the reason why we are doing this is to put the interests of people who are using services at the heart of what we do. And so, making sure that we have the capacity and the capability to deliver on the appropriate enforcement action. And I think we're also quite clear in this document about making sure that it is proportionate in response to the issues, and also the appetite and the willingness of the provider to actually put them right. At the end of the day, what we need to make sure is that we get better care. And I think this will help us. It does, however, and I think you're right to ask the question, David, it does, however, mean that we have to be very mindful of the impact on the capacity of our teams. And I think that's not just within the inspection directorates, it's also within legal services and elsewhere as well. The impact on our capacity if the amount of enforcement that we do increases, because it is incredibly time consuming, and we have the board has heard other examples and seen other case studies of work that we've done, and we had a similar session with the leadership team last week talking through some of the examples that we've had, and the amount of time and effort that it takes for people if we are pursuing action. But it is important that we do that, and it's important that we've got the framework and that we are responding to issues of concern. And frankly, if that means that it is going to take us longer to rate every single service, then I think that that's the balance that we have to cope with.
Okay, thanks. I've got a few. So what I wasn't entirely sure about was whether we will enforce every time there's a need to enforce. Because stage 4 talks about enforcement priorities, which sort of suggests that there might be certain ones that we might prioritise. So I wasn't quite sure whether we were going to enforce every time we felt there was a need to, or whether we're going to use some as a sort of case study to show that, not a study, but an example with a view to sort of as a deterrent, I guess. And if we are going to do that, I guess there's the potential of providers saying, well, it's unfair because they had enforcement action or a fine and we didn't. So it's just to have a bit of clarity on whether it's all or just some, and whether we're going to how and why we're going to prioritise some enforcement action. The other points, they're smaller, but just on the very first page of the enforcement policy, it's actually page 2, and it might seem like a small point, but it's the first thing you read, because it says enforcement is one of the 4 core components of the operating model. And then you've got the operating model, and enforcement isn't mentioned, and it's not clear what the 4 components are. I mean, I know what they are, but just what I mean. So you read that, so you're immediately thinking, I don't know what the components are, and enforcement isn't here, you know. So it's just to sort of, I think we need to be a bit clearer, because it's the first thing you read. And if people are immediately thinking, I don't quite understand the very first bit, you know, just what I mean, it sort of sets the tone. The third point is, I mean, I'm happy to agree that the executive team sign off the impact assessments, but I would quite like to see them, actually, particularly the regulatory impact assessment for, you know, because obviously it could be quite significant. So to have this opportunity just to see it and comment, but I'm, you know, I don't particularly think it needs to come back to the board. And then the final point, which is about implementation, is around the sort of communications around it. And I'm particularly thinking of frontline staff, because, you know, we don't really want the frontline staff to be scared. You know, we need to make this kind of accessible and for them to sort of understand when enforcement action will be taken and won't be taken. And so it's a bit, you know, about being clear and giving the right information so they're not sort of living in fear that we might suddenly take enforcement action out of the blue and when they're sort of working hard. And so it's about the sort of comms and how we communicate it, particularly to frontline staff.
Thanks very much, Kay. On the particular priorities, so on the specific of those sector priorities, the board, we asked the board to look at. First, the board doesn't have to set any, of course, but if you do, it's not then that we would only have regard to those and ignore other things. It's just to give. Let's say, for example, we might take a view as a board that we particularly need to look in the area of learning disabilities, and be particularly looking for cases that fell below fundamental standards. In that case, we would want our inspectors to have regard to that, but absolutely not in a way that said, therefore, and nothing else matters. And I know you know you get that just to the avoidance of doubt. So the expectations our inspectors follow this process. Will we enforce every single potential breach? I think the answer to that has to be no. Yeah. Because not all of them, for example, will we have sufficient evidence to be able to bring the appropriate enforcement. And that is the point of the decision tree, including the seriousness and the persistence and multiplicity, to give a sense of whether a warning notice or prosecution or a cancellation or suspension is the appropriate sanction, or whether a requirement, which we also use what we used to call compliance actions, is most appropriate.
But if we had the evidence, we would go ahead with it, would we? We wouldn't be looking at sort of just examples as a kind of deterrent.
No, that's absolutely right. As long as it was sufficiently serious, persistent or multiple to justify it.
Okay.
And I think that's linked to your question about would one provider say, well, that's not fair? The aim of having the enforcement policy and debating it is exactly to set out our process clearly. And of course, this has been through quite some consultation. The graphic you've got, that's absolutely right. We changed it about very shortly before we submitted it, because the previous one, which did set out very clearly the four operating, actually is just not a very pleasant graphic. Okay. We obviously need to get back and be clear. Where it says action, it really means enforcement, but the point is it's just not clear from the way we read it. We will get that clear. So no, thank you very much for that. David, you were out of the room, I think, for the question about whether the board should see the regulatory impact assessment, even if the executive is to sign it off. No, absolutely.
If anyone would like to see them, that's absolutely fine.
Yeah. Yes, let me debate about that, absolutely. I should have said at the beginning that Hilary has been overseeing the whole programme of the enforcement work, and one very big block of that is, well, I like the way you put it, making sure that our inspectors aren't scared by the task. We have quite a lot in place. We have training.
Yeah.
We have more detailed guidance, and importantly, we have enforcement inspectors, people with a reduced caseload and particular expertise in enforcement to support all our inspectors where they need to take that appropriate action. But Hilary.
Briefly going to say that we've had a communications plan in place and active since September. So as we've been bringing in the fit and proper person requirement and the duty of candour for NHS services, we've been keeping all of our organisation abreast with fairly simple transmit of information, team briefings for use in team meetings, articles on the intranet, including case studies, etc. As we've moved forward into planning for our April changes, we've continued that on a bigger scale. And so we have, there's a weekly update on where we've got to on things. We launched our level 1 training for the entirety of the organisation, including, if the board wishes, I'm sure we could take you through that, which is basics about what's changing, what's staying, and what we're looking for from people. That went live last week. Level 2 training, which is for every single one of our inspectors, registration inspectors, legal staff, some policy staff that are going to be actively using our new enforcement powers. Went live, goes live this week. We are using the current versions, so we are on a really tight timetable. So we have 88 level 2 face-to-face training sessions between now and the middle of March.
all across the country. Level 3 training, which is really quite specialist, which again is 3 days face-to-face for our enforcement advisors and other specialists who need more. And then there'll be additional training that we have secured with our health and safety executives specifically on that piece of legislation. So there's some training plus communications in every single channel that we can work on, so with the aim of every single one of our staff feeling confident and competent and ready to be operating all of this, including FPPR and duty of candour for non-NHS services, of course, which is quite a big deal, alongside all the new enforcement activity as well. So it's pretty comprehensive comms awareness training, and we're following that up through. And throughout we've had inspectors, etc., actively involved in the design, the testing, the assurance, to make sure it feels grounded and real for them.
Thanks, Hilary. Jennifer, yeah.
Thank you. I thought it looked very sensible. It looks very clear. My question is just really about assessing and monitoring variation further down the track, particularly stages 1 and 3. So I don't know whether you'd given any thought to how you might even begin to monitor consistency, particularly in areas where workload is very high.
Yes, so one of the reasons for sort of setting this in the context of the operating model is the commitment we've made is that we will have, for each of those 4 components, a clear set of processes and activities within them that we expect our people to follow, and quality standards at each stage. They're also the quality controls, what we'd expect our managers to be looking for, and the way we report on them. It won't all be in place straight away, but we aim to have those basic processes and activities and standards in place for 1st of April, so that as we go into this new approach, we can log where we are and to what quality, and then report on it.
Well, my question's related to that. I thought it was very, very good, actually, but it is complicated as well, and the examples are very helpful, and I suppose the future examples will be even more helpful. And so my request is that we have a real focus on how this plays out in practice, and that comes back to the board, so that we can see the use of enforcement. But in the end, this is probably one of the most important things we will do, I think, you know, our mission to eliminate the worst kinds of poor care is wrapped up in how we deal with what we find. So I just think this is so important that a report on how often it's used, but also under what circumstances. I think Jennifer's point about consistency, I think, is important. Are we applying consistency across a sector, but also across the different sectors? It will be really useful to get that coming back. And there are simple points like the point I was slightly getting at when we talked about Hinchingbrook earlier, about the timeliness. You know, if you go to a place and something is wrong with care and you tell them and they put it right, what do you then do? Do you then say, well, I'm sorry, we're going to respond punitively because of what you allowed to happen? Or are we just going to take the view that this is primarily about the care that people are getting at the time? And if people put things right, then that will make a difference to our enforcement response. So there are some practical measures that we will have to gain experience of and be able to report on, but very good.
Right, thank you. Thanks very much, Paul. Okay.
David, can I just check, because we haven't discussed the liaison agreement. It was my mistake for not raising it at the beginning, but just to confirm the board is also happy for the Chief Executive to finalise and sign off the liaison agreement with the health with the HSE.
Yeah. Thanks. Yes, that's fine, Paul. Is it? Everyone happy with that? I should have asked about any declarations of interest at the beginning. Can I go retrospectively just do that to keep Eileen happy? Please. Okay. Right, that's it. Coffee time. Oh, sorry. I apologise. Yeah.
Thank you, Chairman. 2 questions, if I may. One relates to intelligent monitoring. Is it currently the practice that all never events, for example, wrong site surgery, like a wrong site hip prosthesis, is that automatically captured, or is it only captured when somebody reports it?
Never events do form part of our intelligent monitoring. They are one of the indicators. If I remember rightly, it's any never event in the previous 3 months. All the technical details on the individual metrics are on the website, but that's my recollection of it, Mr. Pike. We obviously need to have had it reported. We can't otherwise know. It would be we take extremely dim view of anybody not reporting a never event. And we have had examples of that to us. That is an absolute requirement.
Just to add to that, that's exactly the sort of thing that a whistleblower might come forward and say, are you aware that a wrong site surgery hasn't been reported? We would then go in and investigate that.
Thank you. And the other question relates to children and adolescent mental health services, CAMS, which the service is generally regarded, I think, by the department as being not very good across England. How many inspections have there been, and is that view borne out?
In each of our mental health trust inspections, CAMS is a core service that we look at. We look at both it's in terms of inpatient services and community services for CAMS patients. I can't off the top of my head give you a report on exactly how that compares with the rest of mental health. I think there are, in some cases, and we have reported on this, some problems, particularly in staffing, but we can get back to you on that. Maybe, Chair, in the next board report from the hospitals, I could just include an update on the number of mental health inspections, and within those mental health inspections, if there's anything interesting that comes out of CAMS.
If I've remembered my briefing, the answer is 9. So the Health Select Committee, this was a question that we anticipated at the Health Select Committee. I think the briefing that I got was that we've undertaken 9 mental health inspections where we've specifically looked at child and adolescent mental health services. But I don't trust my memory, so I think Mike's suggestion is really good. But I think the general point is we are looking at child and adolescent mental health services when we inspect mental health trusts. But we'll give you the precise number.
David?
Well, I'm afraid I can't promise not to be tiresome.
David.
But I will try not to be long-winded anyway. I agree with Lewis. This report on surveillance is a great deal better than it was in the past. In fact, if your purpose is sitting on the fence between the discouragers and the encouragers, it's brilliant. But I'm going to say here, you should not be sitting on that fence at all. We heard this morning about Hinchingbrook. We heard how the intelligence really didn't prepare people, the inspectors for what they found. I think you should be encouraging every single bit of intelligence you can get, and the intelligence from hidden cameras is very good intelligence. I'm very sorry that I wasn't able to circulate to all of you the changes that I was asking for, but I didn't know your email addresses, but I did send it to Lewis and to Camilla and to David and some others. The common thing that I was saying was to try to make the report more encouraging. And I believe that, contrary to what Camilla says, that was what the board has always along been calling for, to make the whole thing more encouraging. And I hope that you will consider these suggestions and try to end up with a report which is as encouraging as possible. There's one particular, I'm not going to go through them all, but there's one particular one in the guidance at the moment. You seem to accept that some care homes, care providers, will be allowed to ban the use of surveillance equipment. It seems to me that that is not consistent with you telling people that they can, and that you will be interested in the results of these things. I think, therefore, you should take away that, or I think the CQC should not accept that homes and care providers should impose such bans, either in the contracts or in their policies.
David, thanks. Actually, I just far from being tiresome, actually. I mean, you are a really fantastic illustration of what, of the impact that one person can have, actually, on this area. So, I mean, I wasn't being flippant. I was being flippant earlier on, but I want not to be flippant now. And just, you know, thank you for the contribution you make. It's been really important. Good. I think we'll stop for coffee, please.